Good afternoon and welcome to the National Organization for Rare Disorders bi-monthly webinar for our member organizations. My name is Debbie Drell and I'm NORD's Director of Membership and your facilitator for this meeting. I would like to thank everyone for joining us in this webinar featuring our guest speaker, NORD Director of Federal Policy, Paul Melmeyer. This bi-monthly telephone webinar is being recorded and will be made available a week from today. I'd like to just say hello and thank you to the NORD membership team. I'm on the left. Lori Oppenheimer, our membership associate, is in the center, and Kristen Angel, our associate director of membership, is on the right. And we are here at your service. If you need anything, have any questions, you can always email us, membership@rarediseases.org. As a leader of one of NORD's 260 member organizations, you're entitled to all the resources that NORD provides, including state-level advocacy, federal policy, communications, public awareness, education initiatives, patient assistance programs, natural history registries, research, CME, and more. NORD's bi-monthly webinars take place on the odd-numbered month, 6 times a year, and is for members only, providing NORD leaders like you with education, information, capacity building, networking, and direct access to resources. This is our mission. NORD's mission is a patient advocacy organization dedicated to individuals with rare diseases and the organizations that serve them. And you are part of our mission. We're committed to the identification, treatment, and cure of rare disorders. And we do this, it's our mission, and we know that you share this mission with us. During our bi-monthly webinars, we follow the agenda you see on the screen. The format is that we have some national announcements, which comes from NORD, that is news to use for you. And then we have our speaker and Q&A. So if there's questions during the portion of our webinar, we actually have dedicated towards the end for Q&A, and we collect questions throughout the call, and then our presenter will take them if there's time. So that's me on the screen with my sister Alex. We're lobbying our local senator. Alex lives with a rare life-threatening heart and lung disease, and I am going to present the membership updates. Very happy to welcome our new members. The Atypical HUS Foundation is a 501c3, and all of our members are 501c3 nonprofit organizations. This group is dedicated to helping children and families affected by their disease. The HCU Network America is also new, and their mission is to help patients with HCU and related disorders manage their disease and to find a cure. The Lung Transplant Foundation is our newest member, and their mission is to improve the lives of lung transplant patients and families. Their vision is to create a world where all lung transplant patients live long and healthy lives. Lung transplant is rare. We have done our webinars every other month, but we did 2 this month because very recently we had a breaking announcement of the release of a new Quintiles IMS Institute report. We announced it during our Rare Disease and Orphan Products Breakthrough Summit on October 17th. And this report was very critical as it gave us good information on the use and cost of orphan drugs, as well as the current and future outlook for their impact on overall healthcare spending in the U.S. This report and NORD's white paper on this report can be found on our homepage and in our weekly member e-newsletter, which will go out today after this webinar. So you can find the link there to the recording of the webinar that we had earlier in the month, as well as a link to the report. NORD's president and CEO, Peter Saltonstall, was our speaker earlier this month on this topic, and it was exclusively for members only, and he discussed the major findings from the report and how we can work together to raise awareness and educate our elected officials, media, investors, and stakeholders on the success of the Orphan Drug Act during a very critical time in our nation's history around healthcare spending and taxes. So check out the weekly member e-newsletter for the recording link to that. And as we talk about webinars, there is a webinar for all patients, all 30 million people in America affected by rare diseases. So this is not a members-only webinar, but a webinar for your patients. Please let them know There are some really interesting questions that people have. What is the difference between a federal and state exchange? What are important dates around the Affordable Care Act open enrollment? Did you know we're currently in the period of open enrollment? What's the deadline? You'll see it there. Can I enroll any time of year? Does where I live change how and when I sign up for an insurance plan? How does the ACA affect rare disease patients? We are providing this free webinar open to the public to aid rare disease patients and caregivers in navigating what we know can be a confusing process. NORD's policy team, Paul and Tim Boyd, are going to be speaking on this webinar, and it is sponsored by Stonebridge Biopharma. So please share this information. It will also be in the e-newsletter. Oh, hello, Paul. On this slide, what is your organization's annual operating budget for 2017? I know Paul's picture's there. That was a little bit of a typo, but we want to know, and I know that many member organizations are interested in understanding what are the trends. Where do you stand compared to other rare disease organizations and NORD members? How many of our members have budgets of more than $1 million? How many of our members have budgets of under $25,000? And what you see on the screen, in addition to Paul's lovely face, what you see on the screen are the current data that's captured for 2017 from the member organizations that have filled out our survey. We have 260 member organizations. Only 40 of them have filled out this survey. The more of our member organizations that fill out the survey, the better we can understand what we look like, what are our challenges, what are our successes, and how do we operate. And 2 member organizations, several of them have approached NORD asking these questions, wanting to know who works in oncology, who works in neurology, are there organizations like mine? We don't have that data in one place, and we want to be able to capture that to better understand the organizations we serve and to better serve them. So we're conducting this. Encourage you to fill out this survey on behalf of your organization. All respondents of the survey will be entered into a raffle for a chance to win a NORD staff speaker of your choice to travel to your conference or event or meeting, and that's at NORD's expense. So the survey is only open to leaders of member organizations. The link is in the Facebook group of leaders and in our member e-newsletter, and we're raffling off one person, one organization gets a NORD staff member of their choice of our leadership. So we really want you to fill out that survey, and the data is actually very, very valuable. The Social Security Administration established the Compassionate Allowances Initiative to identify and prioritize medical conditions that invariably qualify for disability under their rules. And the CAL initiative helps Social Security to deliver services by making the benefit decisions within days and not months to eligible individuals with the most serious disabilities. Since this program began for compassionate allowances in 2008, the Social Security Administration has approved more than 500,000 claims. They currently have 228 conditions under their compassionate allowances. In a recent member e-newsletter and on our Facebook, we alerted member organizations about an opportunity to be heard and to make a case to add your rare disease on the Social Security Administration Compassionate Allowance list. And we did it. We at a forum that they hosted, connected member organizations that were interested in getting their disease listed. We had them connect to SSA. And at this forum, 7 leaders of member organizations testified on behalf of their rare disease communities. They made a case to put their rare disease on this very important list. And the list of the member organizations that were there include the Congenital Central Hypoventilation Syndrome Network, MLD Foundation, GLUT1 Deficiency, and all the rest of the names you see on the slide before you. And we're so grateful to have made that connection. Anytime NORD gets inside information, gets a resource, gets a connection, or learns of an opportunity, we immediately turn to our member organizations. So if you're not on the member e-newsletter or if you're not on the Facebook group, please email membership@rarediseases.org so that you can get that information. Last but not least, in our updates, the Rare Action Network is a network of grassroots rare disease advocates working on state-level legislation and initiatives, and we bring them together at meetings around the country for training, networking, and hands-on learning and lobbying. And we have 3 meetings coming up. One is actually today in Minnesota. The other 2 are in South Carolina and North Carolina. If you're interested in participating in this, or if you want to join the Rare Action Network, please contact Kristen Angel at 203-744-0100 or kangel, ANGELL, at rarediseases.org. But if you ever have any questions on any of this, you can email membership@rarediseases.org. Now it's my pleasure to take a moment to introduce Paul Melmeyer, who serves as the Director of Public Policy at NORD. In this role, Paul engages in federal legislative and regulatory advocacy on behalf of rare disease patients, including working with Congress to pass pro-rare disease patient legislation. Paul also engages the FDA in ensuring that the patient voice remains strong in drug development and review process, and works with the NIH to ensure that rare disease research environment remains healthy. Prior to joining NORD, Paul held roles at the Center for American Progress, at AARP, and in the United States Senate. So I'm very happy to introduce Paul, who is now unmuted. Paul?
Thank you very much, Debbie, and good afternoon, everybody. This is Paul. I'm very pleased to be here with you today to talk about federal policy access and reimbursement. So before we get into the access and reimbursement, I do need to take just a moment to give everybody an update on what's going on with the orphan drug tax credit, because this is, of course, an issue that you probably have seen that we are really sounding the alarm on, and that we have put forward all sorts of letters and notices and call scripts and emails and so forth. So I just wanted to give everyone an update on where we are. So as we all saw last week, the House of Representatives, within their proposed Tax Cuts and Jobs Act, proposed to repeal the tax credit entirely, without any kind of replacement, without any kind of change to the credit or amending of the credit. They just got rid of it entirely. And over the course of this past week, we're now on day 4 of the hearing going on within the House Ways and Means Committee talking about the tax reform legislation, and nothing has changed within the proposal to repeal the orphan drug tax credit. Over on the Senate side, we're expecting to see the Senate to release their version of tax reform, actually likely later today, probably maybe this evening once the Ways and Means Committee wraps up their hearing. And we're still anxiously awaiting to see what is going to be included within the Senate proposal, because we're very hopeful that the credit will not be repealed within that proposal, but there is still the very strong possibility that the Senate could also propose to repeal the credit, or they could propose to weaken it in ways that would then weaken the incentive for developing orphan therapies. Now, as all of you know, as we've been saying in our messaging over the course of the last even more than several weeks, it's been a year or two at this point that we've been talking about the orphan drug tax credit and why it can be credited for 33% of all orphan therapies that have come to market, and without that credit would have 33% fewer orphan therapies. That means 33% fewer rare diseases that could potentially have their very first treatments, or individuals who are still waiting for treatment for their disease will be left waiting because the tax credit would be repealed. So I really can't emphasize strongly enough how important it is right now to reach out to your communities and tell them that this credit is very much under jeopardy right now, and we really need to make it loud and clear to both the House and the Senate that we cannot repeal the orphan drug tax credit. So linked on this slide right here, hopefully you're able to click on those hyperlinks, are links to an email script for individuals to email their congresspersons, a call script for them to email to call their representative and 2 senators, and just make it very clear that the orphan drug tax credit is one of the only tax credits that saves lives, and that it must stick around and cannot be repealed. Okay, so let's move on to the the agenda for today, in a sense, the main topic, and happy to answer any questions on the orphan drug tax credits at the end of the call as well, for all of you who may have questions on what's going on and what the progression looks like going forward. So we're talking about federal coverage and reimbursement today, and really I just want to kind of start with the overall patchwork quilt of health insurance here in the United States. So as you all know, there are various different programs that offer health insurance to varying different individuals, and each has their own qualifications or eligibility requirements and so forth. And this is a graph that really breaks it down pretty well, and this credit to CBO on putting this together. So, and I'm going to talk about 4 of these areas today. So first, for individuals who are over 65, there's the Medicare program. Medicare also covers individuals with who qualify for the Social Security Disability Insurance Program, as well as 2 diseases that have been carved in. Those are the end-stage renal disease as well as Lou Gehrig's disease. Both any individual diagnosed with those 2 diseases qualify for Medicare. But primarily it is a program that serves individuals who are 65 and over. There's also employer-based insurance, and as you can see, that is the plurality of individuals in the United States have insurance through their employer or their spouse's employer or their parent's employer. But employer-based insurance, again, is the predominant form of insurance in the United States. There's the Medicaid program and the CHIP program. We see approximately 68 million people in the U.S. Are on Medicaid or CHIP. And there's also the AC exchanges, which offer insurance to individuals who aren't eligible to find insurance in any of these other programs. So I'll talk about those 4 more in depth. Now there are, of course, other forms of insurance. You see the military and the TRICARE program here. There are programs for federal employees. There are programs for veterans. There are state-based programs. There are association plans. There's all sorts of different kinds of insurance in the U.S., but I want to focus on just those 4 that I talked about because they are they cover the most individuals with rare diseases and their families. And of course, then there's the uninsured. It's difficult to discuss coverage and reimbursement for those who are uninsured because we're talking about insurance policy here, and for an individual who is uninsured, they don't have insurance, of course. So that's a whole different policy issue that, of course, we're working very hard on expanding access to insurance for those individuals. But for today's purposes, I want to talk about Medicare, employer-based insurance, Medicaid, and the ACA exchanges. So I'm going to start with employer-based insurance because that is the most prevalent form of insurance here in the U.S. And there's really an important distinction to make with employer-based insurance. There are self-funded plans and then there are fully insured plans. And there are very big differences between these 2 that are important to consider when advocating for policy within each of these areas or advocating for oneself or an individual to gain access to better insurance through their employer. So to start with self-funded plans, the key distinction here is that a self-funded plan is a plan that an employer will set up essentially on their own. They are assuming the risk within the plan. They are self-insuring themselves. They're self-funding and they're self-insuring. Now they will likely contract with an insurance company, and that insurance company will then administer the program for them. But in the end, it's the company's money and it's the company's underwriting that goes into a self-insured plan. Now that's different for fully insured. For a fully insured, a company will go out and purchase a plan from an insurance company that insurance company is still assuming the risk for. And these plans are oftentimes sold on the ACA exchanges. They are group plans, and they then have to comply with the rules of the ACA exchanges and so forth. But the reason why there is a big difference between these 2 is because they're regulated very differently, and each of them have very different requirements. Within self-funded plan or self-insured plans, self-insured plans are regulated by a law called the Employee Retirement Income Security Act, or ERISA. Now this was a law passed all the way back in 1974, which was intended on, in a way, strengthening the ability of companies to offer benefit plans, not only health insurance, but pensions and 401ks and all other sorts of insurance options to their employees. And the law was intended on facilitating this better for companies. However, what it did was it preempted, this is a federal law, it preempted all state laws. And so this means that these self-insured plans, these self-funded plans, don't have to comply almost oftentimes quite literally with any state laws. The federal law preempts that. So with that in mind, there are plenty of weaknesses essentially with self-insured plans because none of the state laws that are meant to strengthen health insurance within those states apply. Not only that, but the ERISA law itself federally, which governs this, is essentially untouchable. It's kind of like a third rail of health policy in a sense. It's virtually impossible to amend ERISA. And because of this, there are very, very little patient protections within self-funded plans. For example, of all of those protections we've been talking about within the Affordable Care Act, the self-funded plans do not have to do guaranteed issue per se. They don't have to do community rating. They can still do health status rating. They are still allowed to move forward with benefit exclusions. The only piece of the Affordable Care Act that really does apply to these self-funded plans is the relevant pieces with EHBs, essential health benefits, which I'll talk a little bit about more later, but essential health benefits are those 10 categories of areas that insurers have to cover. Now, within the self-funded plans, they don't have to cover the 10 EHBs, but if they do, if they choose to cover any of them, then they are also having to comply with the ban on annual and lifetime limits, as well as the maximum out-of-pocket limit if they choose to use EHBs. But again, there is just an immense amount of leeway that these companies that choose to self-insure have in structuring their benefit plans. And frankly, because of this, there isn't a whole lot that can be done when advocating within ERISA. Within the ERISA law, there are requirements that the employer cover medically necessary care, but that is not defined, and that is largely actually defined by the courts because there have been a lot of individuals over the course of the last, 43 years that have taken their employers to court because they have outrightly refused to cover certain benefits within their self-funded plan. So while there are legal remedies, what we find to be the best way to advocate for coverage within a self-funded plan is to simply talk to the HR department, because it's the HR department which decides on the benefits. They decide on what's going to be covered and what's not going to be covered, because it's essentially their plan. It's the company's money. They get to decide what's covered and what's not. And so what we find is that if an individual, they either have a rare disease or their child has a rare disease and they're working for a company that has a self-funded plan, if the individual goes to the HR department, talks about the issue, of course the HR department, they want to be offering good benefits to their employees, and so they don't want there to be an issue in which they are just outright not covering certain things that are medically necessary. Now, of course, this is most companies. I can't speak for every company, but when it comes to advocating for better coverage within self-funded plans, oftentimes just talking with the employer, talking with the HR department is the best way to go. In addition, if you're wondering, am I in a self-funded plan, am I not, what we find is more often than not, these self-insured plans are run by the large corporations, the corporations that have enough employees to actually kind of run their own risk pool, run their own insurance within their own company, for example. If you work for a very small organization, then it's much more unlikely that the plan that you receive through your employer is a self-funded plan. It's much more likely that your employer has purchased a plan through the large group market, and now these plans are fully insured. Now, again, the distinctions that we talked about earlier, the fully insured plans, they do have to comply with state insurance laws. They do have to comply with federal ACA rules as well as additional rules. And so for these reasons, these are much more regulated and thus much more likely to cover and offer adequate benefits to individuals within these plans. That means that they have to offer coverage within the 10 EHB categories. They are not allowed to have any annual and lifetime limits. They are they have to use a community rating rather than health status rating in setting their premiums. There can't be any benefit exclusions. There has to be guaranteed issue. All of those rules that have been enacted at the federal and the state level over the course of the last 10 years, let's say, if not longer in some states, apply to these fully insured plans. Now, when it comes to reimbursement within these plans, this is still largely plan specific. What happens between the plan and then the offers of therapy, whether that be the doctor, whether that be the hospital, whether that be a pharmaceutical company who's going to be negotiating for covering a drug under that plan, that's all plan specific. It's the insurance plan will talk with the doctor's office, they'll talk with the insurer, or they'll talk with the hospital, they'll talk with the company, and then they'll agree on a reimbursement rate, or they'll agree on coverage. Now, oftentimes these plans, of course, won't even cover certain doctors, they won't even cover certain drugs, and thus they're not included. But it is up to the insurance plan specifically, by and large, on what they cover, so long as they are covering those essential health benefits within those 10 categories. And if, for all of you who remember before the Affordable Care Act, those 10 essential health benefits didn't exist, so there was huge variability in what these plans would cover because there was simply no requirements to cover anything specific. So with the Affordable Care Act being enacted, they have to cover care within those 10 categories. And I keep mentioning these 10 categories. I should probably mention a few of what they are just so you can wrap your head around them. These are prescription drugs is one category. Maternal and infant care is a second category. Ambulatory services is a third. Inpatient hospital services is a fourth. Outpatient services is another. Kind of just dividing the main categories of what you expect an insurance company to cover, those are the 10 EHBs. So when it comes to advocating for changes either personally for yourself or policy-wise within these fully insured plans, much of the advocacy either would happen again with the employer because while they don't set the benefits, it is the employer who chooses the plan each year. And so they want to be sure that they're purchasing an insurance plan that is adequate for the employees. So if an employee comes to them and says, hey, the network's awful, all of the specialists, all of the docs, all of the whomever, all the hospitals, drugs, whatever, aren't covered in the plan you purchased, get a better one, then they do have the opportunity to do that next time in open enrollment, which actually conveniently is basically right now. So there's real value in talking to an employer if the fully insured plan that is being offered is inadequate. Largely, these plans are regulated at the state level, and state insurance commissioners oversee these plans. And each state also has, most likely has a consumer ombudsman or a consumer advocate. And these individuals that are, state government employees, their sole purpose is to be there for you if you feel that an insurance company is denying benefits illegally, if they aren't complying with any of these important patient protections, if they're not following the law. These guys are there to listen to the general public about why that insurance company is not following the law. And they've actually been very successful in ensuring compliance, because what happens is if, let's say I went to the DC ombudsman saying, my plan doesn't comply with coverage that it needs to be complying with, then the ombudsman can go to the DC insurance commissioner, and that insurance commissioner has legal and regulatory remedies to force that insurance company into covering what it needs to be covering. So this largely happens at the state level, and there's a link here. We actually have a state-by-state health insurance information page that links to all of the state's insurance commissioners as well as consumer ombudsman or advocates if they have them, and it takes you straight to the page to fill out an online complaint form and just walks you through the process of doing that as well. Again, this is all state-based. And then, of course, there are legal remedies if all of this isn't effective, and that would also largely be conducted through the insurance commissioner's office. So, again, that is the general landscape for employer-based insurance, whether it be self-insured or fully insured, and the ways for which individuals or organizations can advocate for changes within those two areas. When it comes to whole-scale policy reforms, while I said it's incredibly unlikely anything will be done with ERISA, at least anytime soon, there are options, there are ways to pass state laws to force companies to offer in fully insured plans certain benefits. And we see this being done with certain communities of requiring companies or requiring fully insured plans to cover certain benefits, to cover certain kinds of therapies and so forth. So that is definitely a overall policy opportunity in a sense to go to state legislatures and say, hey, pass a law to require insurance companies in the fully insured market here to cover this and that. So there's also larger policy options there. So I'm going to move away from employer-based coverage and into Medicaid and CHIP, because that is the second largest insurance carrier in a sense for individuals with rare diseases. And just to talk about who Medicaid covers, it's actually a wide array of individuals. You'll find many children covered by Medicaid and, well, of course, the Children's Health Insurance Program. And actually over 50% of individuals covered under Medicaid are children, because the eligibility for Medicaid is the widest. It's the most inclusive for kids. And so you'll find many kids across the U.S. who are covered by Medicaid, either fully by Medicaid or supplementarily by Medicaid, if that's a word. And so Medicaid is a huge cover for children. In addition, there are many individuals who are elderly, who are on Medicare, who are retired, who perhaps are lower income and don't have the ability to pay the premiums and other cost sharing and so forth that are within Medicare, which we'll talk about a little bit later. And in that way, Medicaid steps in and helps them cover that. Medicaid also covers the majority of individuals in long-term care facilities, both individuals who are elderly and are in a long-term care facility. They're most often covered through Medicaid unless they have long-term care insurance, but that is unlikely. As well as individuals who have serious disabilities, either intellectual or otherwise, who need to be cared for 24/7 in a facility. They're likely to be covered by Medicaid. So Medicaid is largely regulated by the states. It's a state program with federal assistance. The federal government will contribute anywhere from 50 to 75% of the costs of a state's Medicaid program. And it only will require certain mandatory services. And you see these on the left. And these, again, are very broad categories that there's a whole ton of leeway within state Medicaid programs for what to cover within these categories. But what you see over on the right, selected optional services, prescription drugs is technically an optional service for a state to cover, which is kind of difficult to wrap your head around, but it really goes to show just how much leeway states have in structuring their Medicaid programs and how important it is when we talk about changing Medicaid for advocating on a state level due to the great leeway that they have in structuring their programs. So with this in mind, there is very large variability in not only the generosity of Medicaid programs across the U.S., but also just eligibility for Medicaid across the U.S. This is a map that we pulled from our state policy report card, and this shows our evaluation of Medicaid programs across the country and how we believe if their eligibility for Medicaid and CHIP is adequate. You see a lot of states are doing pretty well, and then there's a lot of states that aren't. And in those states, we find individuals with rare diseases or individuals who have children with rare diseases who are looking to gain Medicaid coverage are oftentimes denied, or the benefits within Medicaid, if they're accepted, are quite paltry. So with this in mind, there are various different ways to get involved in advocating for better coverage within Medicaid. Before I move to that, I should say for reimbursement for Medicaid, this again is on state-specific level. So Medicaid agencies will decide within your state what docs to cover, what hospitals to cover, what's going to be in-network, what's going to be out of network. Now I have except for prescription drugs here with asterisks because technically there's a law that requires Medicaid agencies, Medicaid programs to cover any FDA-approved therapy. It's a rebate law. Basically, if the pharmaceutical companies agree to pay rebates, then the Medicaid programs have to cover them. But there's the asterisk here because Medicaid programs are getting more creative in finding ways of not covering certain prescription drugs. Which brings me to my next slide. which is how do I advocate for changes to Medicaid within my state. So as I said, this is largely state-specific, so state laws are going to play the largest role here. And we see a lot of states strengthening their Medicaid program. We see a lot of states weakening their Medicaid program through state laws. And this, again, is very loosely regulated by the federal government. What I mentioned earlier about creative ways for states to not cover certain drugs coming to market, they're actually using what are called Drug Utilization Review Boards, or DUR boards, which are boards that are within the Medicaid agency, which if a new therapy has come to market and they're going to consider whether or not to cover it, well, they consider whether or not to cover it, and then if they are, to what extent, essentially, who's eligible for it and who's not. And these DUR boards are being used to delay coverage, to just not cover altogether through kind of creative other means of finding ways around the Medicaid rebate laws. And so it's another opportunity for individuals with rare diseases to advocate at a state level for better coverage for certain therapies. Within certain states, they have taken a kind of managed care or HMO program within their state, and so it can actually be plan-specific advocacy rather than overall state Medicaid agency advocacy. And then there's also appeals processes within Medicaid at the state level. And there's more information on our state-by-state insurance webpage here. Again, for each state, we have each state's Medicaid agency listed, as well as the Medicaid appeals process if Medicaid is denying access to certain care. So that's at the state level. At the federal level, there's still a lot we can do. First of all, we need to protect federal funding for Medicaid. This was an issue that we were dealing with for the last 10 months or so in conversations regarding the Affordable Care Act repeal and replace initiatives that were ongoing, as these bills largely propose to cut Medicaid funding anywhere from about $300 billion to upwards of $1 trillion over the next 20 years. And in addition, those mandated coverage categories, we at the very least need to be sure that they're not weakened, but there's also ways to strengthen them, and that can be done at the federal level. States have actually ways to even get out of the limited regulatory requirements the federal government has through waivers. These waivers allow the states to structure their programs even more, on one side you could say, innovatively in a way that can be state-specific, but on the other side, they can get out of a lot of important requirements, or they can apply a lot of other facets to Medicaid that could be really problematic for individuals with rare diseases. And that's protection against problematic waiver programs. But when I say waiver programs, it can go both ways. It can be problematic in the sense that they want to cut back coverage, but it can be beneficial. And I can use the example of the home and community-based services waiver programs, the 1915 programs, which states can choose to seek a waiver from the federal government to cover even more individuals. And then the federal government will help them cover them through additional funding. Now, the home and community-based care services programs are waiver programs states can opt to do, and what these programs allow for is care in the home, in the community, that then the federal government and the state will reimburse for. And we found this to be incredibly impactful for a lot of families with individuals with rare diseases, because that means that the parents can work or the child can be taken care of at home. It's really been revolutionary for a lot of individuals out there. And some states have chosen to do it, others have not. That's another state-specific opportunity to advocate right there. All right, so that is the Medicaid program. We're going to move to Medicare. So Medicare, as I mentioned earlier, covers individuals over 65 years of age, as well as those who qualify for Social Security disability insurance and for those two diseases I mentioned earlier. So important things to consider within Medicare. There are kind of four different parts within Medicare. There is Medicare Parts A and B. Part A covers hospital services. Part B covers physician services. In 1997, I believe it was, Medicare Part C was created. And what this was meant to do was kind of create an alternative pathway for individuals who wanted to kind of purchase, in a sense, a comprehensive insurance plan similar to what you would do in the private market. And actually, these are still largely private plans administered by private insurance companies, but you do it with Medicare money. You do it subsidized by the Medicare program. And thus, these Medicare Part C plans are rather comprehensive, as private insurance would be. Now, back in 2003, the Medicare Part D program was added, and this covers prescription drugs. But you kind of see the two different pathways here. For an individual who is qualifying for Medicare, they can either purchase a Medicare Part C plan, which covers generally a lot of stuff, as well as, or they can go the other route, the traditional Medicare route as it's known, and they can get Medicare Parts A, B, and D, and then if there are any additional gaps in A, B, and D, they can purchase a Medigap plan, which, as with gap in the name, tells you it's supposed to cover the gaps. So under Medicare, this is largely uniform across the United States because Medicare is almost exclusively federally run. There is essentially no role for the states within the Medicare program. This is entirely administered by the federal government. This is particularly true with Parts A and B. It is entirely uniform across the U.S. Part D, there actually is some variability across the U.S. because the Medicare Part D program is actually a way for individuals to purchase subsidized prescription drug coverage from private insurers. So what private insurers will do is they'll put together a prescription drug program, they'll bring it to the Medicare, the Centers for Medicare and Medicaid Services, CMS for short, and they'll say, we want to sell this to Medicare Part D recipients, and then Medicare will ensure that it complies with all sorts of rules. If it does, then Medicare will say, great, you have checked all the boxes, we'll now cover a lot of the coverage, and I'll get into the coverage structure in a little bit. But these plans can be national, they can be regional, they can be state-specific. It depends on what the specific insurer wants to do. So for that reason, you can find some variability across the U.S. in what Medicare Part D plans are offered, but largely it's still rather uniform, especially compared to Medicaid and private insurance options. So I mentioned the Medicare Part D cost sharing. This is how it works, and I'm about to get into a couple slides that really get into the nitty-gritty of health policy, so I'll apologize, up front. But when it comes to reimbursement and coverage policy, these things can really drive what's covered and what's not, what's reimbursed for and what's not. And so if you're able to follow along, I'm impressed because this is really as complicated as it gets within health policy. So to start here with the Medicare Part D cost sharing, this is for last year. With Medicare Part D, initially the individual will pay an annual deductible, which is $360. That's out of pocket for the beneficiary. From there, the individual upwards to $3,300 of coverage will pay 25% coinsurance, and then the health insurance plan will pay 75%. And then we hit that dreaded donut hole, the facet of Medicare policy that I think everyone's heard about, either through ACA debates or otherwise, but perhaps aren't really sure what that is. Why is it called a donut hole? Well, it's because it's in a sense it's a gap in Medicare coverage, or it was a gap in Medicare Part D coverage before the ACA was enacted. And that actually, the donut hole is continuing to be closed. It's still closing. It will fully close within the next few years. But within this, the beneficiary pays actually 45%, which is pretty high. The plan will pay 5%, and then the drug manufacturers will actually contribute a substantial amount to the coverage. So once the individual is out of the donut hole in coverage and they get to catastrophic coverage, then Medicare pays 80%, the plan pays 15%, and then the beneficiary pays 5% in perpetuity. There's no out-of-pocket maximum within these plans, which is actually really problematic for a lot of individuals, something we're working on. But 5% for the remainder of the plan year. So this is the way that an individual under Medicare Part D would work through the different levels of cost sharing as they work through the year and as they gain access to their therapies. Within reimbursement policy for Part A and Part B, this again is really where it gets complicated. So reimbursement for hospitals under Medicare is governed by what's called the Inpatient Prospective Payment System, or the IPPS. And how this works, and this is actually very similar for outpatient services as well, is that the Medicare agency will actually look at previous years and how much it costs to cover certain care, and then they will prospectively pay the hospital for what they expect that hospital to incur over the upcoming year. So it actually, rather than classic fee-for-service, meaning that the hospital or doctor does this certain procedure or administers this care. They bill the insurer pays for it. Instead, within Medicare Part A, Medicare actually is paying the hospital up front based upon what they expect the hospital to incur that year. Now, the way that they evaluate this is through diagnosis-related groups. And this is based upon, again, diagnoses, and they'll reimburse. And reimburse really isn't the right term for it because that kind of alludes to retroactive reimbursement or retroactive payment, where actually this is prospective payment. They will evaluate how much it will cost for a hospital to administer certain services based upon the diagnosis of the individual who is there. So they'll pay for a certain amount for a knee replacement or a heart valve replacement, or and they'll actually, they're going in a direction where they're bundling care even more and more for even more diseases. So instead of paying for the average cost of a heart valve replacement, they'll pay for the average cost for heart disease in general. The direction they're going in, but not what we're talking about today. In any case, these DRGs are actually important to advocate for, because especially for individuals with rare diseases, we're not really going to have diagnosis-related groups for the rarest of rare. And so because of this, hospitals within the Medicare Part A system, it's a system that's not set up with rare in mind. And that is something that we're all too familiar with, and this is a great example of that. And so for these reasons, it's important for organizations to be sure that when the Federal Center for Medicare and Medicaid Services are creating these DRGs or are working on this policy, that rare disease patients are represented. Within Part B, which is docs, there are kind of different ways for physicians to be reimbursed for their services. For physician-administered drugs, so for individuals who are gaining access to a therapy that the physician is administering within the clinic or within the hospital or within their doctor's office, some infusion therapies or chemo, for example, then they're reimbursed at average sales price plus 6%, or ASP plus 6. But by and large, Part B is still fee-for-service. A physician, does a certain service, they'll bill Medicare, Medicare will pay them back. And that's based upon a specific physician fee schedule. And now this is all changing to an extent because a couple of years ago, there was a law that was passed, so acronym is MACRA, which includes a quality payment program, which instead of just straight up reimbursing a physician for what the service was, they'll actually keep in mind the quality of the physician and reimburse for the physician for how well she is doing instead of just what she is doing. So just very briefly, and this is the most complicated this will get, this is how the physician payment system works within Medicare under Part B. The way that they evaluate the RVUs, or the relative value units, what they will do is they will take what they think the cost of the care was, what the how that differs geographically, because a physician in New York, it's going to possibly cost a lot more to do something than a physician in let's say Duluth. And then they'll also take into account the malpractice cost the physician, the insurance physician has to pay. Then they'll multiply all of that by a conversion factor, which is updated yearly. It's supposed to account for inflation because costs will grow, and that's how much they will then repay the physician for. Now, the reason I'm telling you this, because I can assure you it's probably not directly relevant in your lives right now, but it's important because this is what drives physician action. This is what drives oftentimes how physicians are reimbursed, who they want to take on as patients, how they care for them, who's attractive and who's not. And again, this is influential because individuals with rare diseases and care for rare diseases can be left out when making these calculations, something that our community needs to keep in mind. All right, and finally within Medicare Part D, reimbursement is negotiated by plan. It's very similar to private insurance. There are certain rules of coverage. There are 6 protected classes of therapies that every single therapy within that class must be covered. A class is kind of, the whole prescription drug ecosystem is divided into, or prescription drugs are divided into classes based upon either the kind of chemical underpinnings or the diseases they treat. So, chemo would be in one class, metabolic conditions are in another, certain antivirals are in another, and so forth. So there are 6 classes such as antivirals or therapies for HIV/AIDS and others that every single drug needs to be covered in every single plan. But other than those 6 classes, 2 drugs need to be covered per class in each Medicare Part D plan. So how do you find adequate coverage under Medicare? You would go to Medicare Plan Finder, or you go to your state health insurance assistance program that's set up to help individuals sign up for Medicare. Now, if you're signed up but you're not receiving adequate coverage, or you're getting denials from Medicare, there's a Medicare appeals process that you can go through. And really a fantastic resource in navigating all of this is the Medicare Rights Center. They actually have a hotline that's staffed with individuals who know Medicare inside and out, who are there to talk about what denial of coverage or what issue an individual under Medicare is facing, and how to potentially appeal for coverage for under that plan. So that's kind of advocating for personal issues within Medicare. Policy-wise, in general, the Center for Medicare and Medicaid Services, I forgot services in there, is very influential in how they structure all of these things I've been talking about, the physician payments, hospital payments, Part D, all that kind of stuff. They go through annual rulemaking and all of this, where they reevaluate the program and think, how can we make it better? That's opportunities for all of us to contribute and, well, tell them how they can make it better. In addition, there are ways for advocating for off-label coverage within Medicare. For example, if there's a therapy that is shown to be safe and effective through peer-reviewed empirical studies, that data can be brought to Center for Medicare and Medicaid Services as a justification for covering a therapy off-label, and they will oftentimes do that. What they'll do is they will make a national coverage determination, meaning that all plans across the U.S. need to make a change and cover this within their plans, and that's the way to do it for off-label coverage. And then again, if we want to change any of this statutorily, we go to Congress. If we want to change the 6 protected classes, or if we want to change the cost sharing, or if we want to require certain things within the Medicare program, we go to Congress and we say, hey, this needs to be changed. You need to cover this. You need to change that. We go to Congress. We don't go to the states. We go to Congress to make those requests. All right, I'm running out of time, but I just want to cover the ACA exchanges just very briefly. So as you all know, an issue that has really been front and center in health policy for the past year, ACA in general has. This, again, is governed very similarly to those fully insured plans I told you about before that employers can purchase. They have to comply with the same state laws. They have to comply with the same federal laws. And there actually are additional requirements for how these are structured and what plans must be offered within state exchanges. And again, the reimbursement is set on a per plan basis. But when discussing how to advocate for oneself within exchange plans, there are the same state mechanisms we discussed before. The insurance commissioner oversees these plans. The state consumer advocate is there to answer any questions or help out with complaints when it comes to these plans. But there are additional federal standards that are put forward by the Center for Medicare and Medicaid Services each year on these plans through what is called the Notice of Benefit and Payment Parameters. It's a fantastic name, a really boring name for a really important rule. And I mentioned this because it's actually out right now. It's out for comment right now. And unfortunately, there are a lot of things that are very concerning in there. So I mentioned this because stay tuned. You'll probably be hearing more from us on this in the next couple of weeks of us advocating for changes within the Notice and Benefit and Payment Parameters to ensure that these exchange plans remain strong for our population. And then, of course, there's all the legislative stuff, both protecting the coverage gains that we made within the Affordable Care Act for individuals with rare diseases and their families who purchase insurance through the exchanges, as well as strengthening coverage within the exchanges as well. Okay, there's 7 minutes left. I want to be sure that I left at least a few minutes for questions. So with that, I'll turn it back over to Debbie.
Thank you so much, Paul. I am going to admit that I will probably need to be watching this webinar again. I was taking notes, a lot of notes. So much good information, very information dense and very good information to know. So if we have any questions, the way that we will collect the questions is through the chat function. So please use the chat function where we won't be unmuting the lines. The chat function is a circle button on the lower left side of the window. It's light blue with 2 white speaking bubbles. And it's on the left-hand side of the raise hand button. So if anybody has any questions, I see Rita has raised her hand. Rita, we're not going to be unmuting the line, so if you wouldn't mind using the chat function to submit your question, that would be terrific. We'll give you a moment for that. And actually, I'll send Rita a chat and see what her question is. We did get feedback that someone appreciated the presentation, that you explained it well. There is a question, will the slides be available online after the call? And I can answer that to say that the webinar recording will be available after the call. Paul, would you mind if we made a PDF version of the slides available as well?
No, absolutely not. That sounds just fine.
Okay, great. So that will be included in, not today, but next Thursday's e-newsletter. So we have a question, and this one comes from Deanna. Deanna asks, on one of your Template Tuesdays, this is not, well, it's sort of advocacy related. Here we go. So I'll just explain quickly. Template Tuesday is something that membership has instituted on our Facebook group, where every Tuesday we upload a template document that members can use. So Deanna's question is, one of your Template Tuesdays, would you consider sharing templates for how to engage an HR department or an insurance appeal letter so that we can share with our membership when they have insurance problems? So the answer to that is we're willing to easily post something like that. Paul, do we have a template for how to engage an HR department or an insurance appeal letter?
So I don't know if we have one in-house currently, but what we can do is what I think would be valuable is to actually reach out to the community and ask if anyone has been successful, because I know that many individuals have been, and perhaps they can share some best practices on what worked for them, because I would imagine it could be different per company, and perhaps letters were the best way of doing it, perhaps one-on-one conversations. But I think this is something that we'd want to hear from our community members on what has been successful for you, and if there was a particular form that was particularly helpful, then maybe we could distribute that as a template.
Oh, that's a great idea. So to answer the question, Deanna, if you or a member of NORD's membership team can go to the Facebook group and ask for this, whoever gets there first can ask other members to share their template letters to engage HR or insurance. And then whatever we collect, we can take a look at and upload on a Template Tuesday. Another question that was asked is now from Rita. She says, there are often issues with Medicaid only providing coverage within the state and not a doctor in that state with expertise in the rare diagnosis. So it's sort of a comment, but then she follows up to say, some physicians are beginning to not accept insurance and require the patient to pay out of pocket and request insurance reimbursement. Are others experiencing this in rare disease patient populations? So that's a question that can be asked to the Facebook group of leaders, Rita, and we can ask that for you if you're not in the group, but we encourage you to join. But Paul, what would you say to that?
So I'll answer the first question on Medicaid. It's not a question, but it's a statement. But it's an important point that's being made that oftentimes there are experts within states, but Medicaid is choosing not to reimburse for them. What to do in those cases? There are several recourses that individuals within those communities can go about. First of all, they can just advocate for that physician to be covered through the state Medicaid agency. There's the appeals process. If a physician isn't covered, you can go through the appeals process and say, this is the only physician that perhaps is offering care for my specific rare disease within my state because it is so rare, and he needs to be within network. That can go through the appeals process. Talking with the state Medicaid agency is important, and if all of that fails, if they're still going to be stubborn and not cover that individual, then state legislatures love to hear about ways that they can bully the administration into doing better for their constituents, and they would love to hear about Medicaid agency not covering an individual who is an expert who could offer expert care. So those would be my recommendations on the state Medicaid piece. As for physicians that are not accepting insurance or requiring the patient to pay out of pocket, that is their prerogative, unfortunately, at least as far as I'm aware. But that is still something that is very concerning and could be addressed through state regulation or state law. That would have to be at the state level. So that is something that I think would want to do kind of a landscape analysis on to see that if it's a problem or if it's a problem that's more prevalent in some states rather than other. And then if it is, consider some state recourses if necessary.
Great. And then we have one more from Steve about how much is the total funding needed to keep the orphan drug tax credit in place?
Well, so one problem we're facing is the Joint Committee on Taxation, which is kind of like the advisory body to Congress for tax policy, has told Congress that the orphan drug tax credit costs $54 billion over 10 years. Now that is a lot of money, and that is a lot more than any of us expected for them to score the orphan drug tax credit. So we believe that the reason for why Congress has, at least on the House side, proposed to repeal the orphan drug tax credit is because simply they need to find $54 billion to pay for other things they want to keep into the tax bill, including repeal of certain other taxes, including lowering of the corporate rates, including all other sorts of things that cost a whole lot of money. So that $54 billion is a very appealing piggy bank in a sense for Congress to use to pay for other things. So that, I guess, kind of answers the question of how much funding is needed. It's not so much that we need to find $54 billion elsewhere in order to ensure that the orphan drug tax credit remains in place. We just need to be sure to tell Congress that this tax credit, even if it's $54 billion, is worth it because of all the lives that are going to be saved for individuals with rare diseases over the next 10 years. That it doesn't matter what the score is here. We're talking about kids still waiting for their very first treatment who have a rare disease. So that's really the messaging that we're highlighting of why the orphan drug tax credit is important to keep around.
Well, that's all the time that we have for today. We're just a minute after. Thank you so much, Paul, for giving us a really good presentation and for all the questions and engagement from the dozens of leaders from our member organizations on the line. We're going to end with a reminder that our next bi-monthly membership call is December 6th at 1 p.m. and we have a surprise guest who will be joining us to talk about ICD-10, what is next for 2018. Thank you so much, everyone, for joining us, and stay tuned for our member e-newsletter today in your inbox. Email membership at rarediseases.org if you do not receive that, and if you would like to have access to that and any other benefit that you heard today. Thanks so much, everybody. Bye-bye.